find another charger port.
All right, so all right, cool. So right now it's starting to share. Right now it's starting to share. So are you starting with that one?
Yeah, yeah.
Cool. So that's uploaded here. Just
How did you swipe?
oh, 3 fingers.
Oh, yeah. Okay.
Yeah. Wait, do you do that too?
No.
No.
I'm not as smart as you. Is it recording? Oh gosh.
It's okay. So just use those two, etc.
Yeah.
So you just have to press both.
Finish that.
Once you finish, just go here,
Oh, it's 3 finger swipe. I'll try.
and then you go here. Yeah.
Okay.
Is that all good?
Yeah.
If anything happens, just give me a shout. I'll be like sitting up there.
Okay.
Okay. Cool. I think pretty much everyone's here, so we're good to go whenever you're ready. Yeah, it's good. Yeah, mic's working there. It just doesn't record. That was the problem.
Okay.
Yeah. I'll check if anyone's outside.
So I might get started, guys. Alrighty, so today we'll be talking about some miscellaneous topics. So it includes ID, derm, pathology, and breast, which are, I guess, topics that I guess you consider like that's not taught very well. So hopefully you'll try to do a brief one through of all these 4 topics. Obviously, I won't be able to cover everything in detail, but I understand that you guys have a pathology test coming up next Monday. So I think that's derm. Is it MSK and heme? So what I've done is this will cover derm and breast, and I've also uploaded, I guess, some buzzwords for MSK and heme, because we obviously won't be able to cover everything today. So hopefully that'll help with your test revision for Monday. So let's get started. So, hey, what happened here? Sorry. Whoops. Sorry, I'm just trying to get this to work on the laptop. I think I accidentally. Oh, there we go. Sorry. Okay, let's get started on ID. So this is from the matrix. So obviously ID covers overlaps with a lot of other systems. So I'll be running over, I guess, some important conditions for you to know, as well as the green conditions highlighted here. So in terms of, I guess, general principles of knowing how to choose antibiotic, I think the most important thing to know is like what type of bacteria you're treating. So general principles are gram-positive, are gram-negative, anaerobic, atypical. And then from this, you can determine what the most effective antibiotic is in terms of empirical treatment. And also important to know things like what would you do in case of allergy, and also consideration patient factors. So I'll go through those. So general principles of choosing antibiotic. They probably won't test you on this, but just good to know as a for background. In terms of a good reference to, I guess, find out what's the best antibiotic treatment, I would recommend ETG because it's Australian based. So in terms of, I guess, basic principles, what I'm sure you already know. So we know cocci are round, bacilli are rods, gram positives are purple, and gram negatives are pink. And this is clinically important because that determines what type of antibiotics we can use. So in general principle, penicillins are not effective against gram negatives. So this is from Ben Amberg's notes. So I think it's a really good, I guess, summary of what types of gram-positive bacteria are there, and he's got really good notes on this topic as well. So I recommend looking at it if you want a bit more background. So in terms of what gram-positive bugs there are, so Staph aureus is we know is a cocci, and it's purple because it's gram-positive. And the treatment of choice for MMSA, if it's methicillin sensitive, is Fluclox. If it's methicillin resistant, vancomycin is your antibiotic of choice. For Streptococcus, the first line treatment is Benpen or amoxicillin oral. And for Enterococcus, the best treatment is amoxicillin. So this is something I often get confused last year, was the difference between staph and strep. And the difference, I guess a good way of remembering is that strep comes in as like a strap, so it comes in chains when you look at it as on a culture, versus staph, which is sticky, which looks like a bundle of grapes. And from there you can determine the treatment. So staph, strep looks like strap in that it looks like chains, so you treat with Benpen or amoxicillin, and staph looks sticky like grapes, and you treat it with flucloxacillin or dicloxacillin. So now we move on to gram negatives. So in terms of an important gram negative to know, important one is Neisseria meningitis. Sorry, your laptop keeps on popping up messages and it keeps on, like someone's trying to, I think, sorry. I think someone's trying to message you or something.
Oh,
and it
that's
keeps
a call.
on like,
that's all good. Can you still change slides? Oh,
can
yeah.
you
Okay.
change it back? So when it pops up, it like, oh, perfect.
There
Sorry. The most important gram negative to know is Neisseria species because it's the only gram negative that's a cocci. So if it's pink, which means gram negative and it's a cocci, then you know it's Neisseria. And the treatment of choice for that is Benpen. And then another important gram negative to know is Pseudomonas. So I put a little box here of the antibiotics with Pseudomonas covered. And I guess a clinical important point is that all the antibiotics that can treat Pseudomonas, only ciprofloxacin is the only one that's oral, so that's why you reserve that as last line, because you don't want to exhaust all your oral agents. For E. coli, treatment of choice is trimethoprim. That's typically implicated in UTI, but you can also use gentamicin if it's urosepsis or there's pyelonephritis. So moving on to anaerobics. So basically the main characteristic these bugs have is they don't like oxygen, and the treatment of choice typically is metronidazole for that. There's a summary here. And move on to atypical. So this is another thing I got confused with last year. So atypical refers not to clinical features, but more of the microbiology. So atypical bugs typically don't stain well in gram stain, so they don't really cause gram positive, gram neg, and they're typically intracellular organisms. So the main three atypical organisms, I remember CML, is chlamydia, mycoplasma, and legionella. And that's important when we think about the treatment of pneumonia. And that's why we use doxycycline for atypical cover. Moving on, so another group of bacteria you might have heard of is the encapsulated bacteria. And there's a bit of a mnemonic to help you remember what those are. And I guess the clinical relevance of this would be in patients who don't have a spleen, so asplenism, whether it's from removed for motor vehicle accident. This is important because they're more vulnerable to infections from encapsulated bacteria. And so it's important for them to get immunizations against these bugs. So move on to antibiotics. So I think the best way to learn antibiotics is to learn the disease that it's associated with and antibiotics together. And instead of learning specific antibiotics, focus on the conditions and the empirical treatment as well as their side effects. So the first class is penicillins, and as I already went through this, so strep, you use benpen, enterococcus, use amoxicillin. For staph, you use Fluclox. If you need a penicillin that also covers Pseudomonas, you pick Pip-Taz or Tazobactam. And Augmentin Duo, which is amoxicillin clavulanic acid, covers, is very broad spectrum, can be quite broad spectrum, covers gram-pos, gram-neg, and anaerobes as well. So in terms of side effects, with any antibiotic, so you can always have, GIT side effects and allergy, but it's also important to remember that penicillins also have a cross-reactivity with cephalosporins and other beta-lactams as well. So important to keep that in mind. So I guess moving on to exam question. So a 21-year-old woman presents with a 3-week history of tiredness associated with sore throat and tender cervical lymph nodes. Atypical mononuclear cells were found in the peripheral blood sample, and she developed a fine rash after given amoxicillin for a sore throat. Her spleen is palpable and the costal margin, and it's soft. What is this? So, yep, it's G. So it's infectious mononuclear. So reason I put it here with penicillins because I guess a classic association is amoxicillin plus EBV or infectious mononucleus causes a rash. And it's important to know this is not actually an allergy, but more, I guess, a reaction because of their underlying condition. And that's the reason why we give phenoxymethylpenicillin for sore throat. So because sore throat is typically due to bacterial causes, typically caused by strep pyogenes, and you're thinking, oh, if amoxicillin covers strep, why don't we use that? But it's because of this known reaction that we avoid amoxicillin and use phenoxymethylpenicillin. And also important to note that EBV is also a green condition on your matrix, and the I guess the investigation that you use is monospot. So if you see monospot, that's specific for EBV. EBV also has a clinical presentation that's classically associated with fever, sore throat, lymphadenopathy, and hepatomegaly, so big liver and spleen. And personally, I felt in terms of, I guess, how it will present in an OSCE situation, it will probably present as like a person comes in with a lump. So I included this because I felt like it's not really covered very well and I had trouble. So a lump, history, I sort of listed here. So do a malignancy screen, infection screen, look for autoimmune symptoms, look at time causes, tender, non-tender, is any exposures, any high-risk behaviors, any itch, any medications that could be causing it, as well as how you approach an exam. It's unlikely they'll come up, but if they do, it will probably be EBV because it's a green condition or some form of malignancy. So I've just listed some features you can look out for. For EBV, typically in terms of the lymphadenopathy, will typically affect the anterior cervical chain. And I guess signs to make it less likely to be malignant would be small ones, so less than 1 cm. I read it up to date, there's no chance of malignancy if it's a small lymph node, so that's reassuring to know. And then non-malignant will tend to be soft, will tend to be mobile, and tend to be tender. And yeah, so there's just some things you can read when you go home. Next antibiotic class is cephalosporins. I guess the main thing to know is that as you increase the generation, there's more gram-negative coverage. And so I think the most common one we use in the hospital setting is ceftriaxone, which has really good gram-negative cover. This is probably not important, but I just include it here anyway. So escapement organisms are known to have high risk of resistance to cephalosporins and penicillin, so just something to keep in mind. So moving on is carbapenem. So they're very broad spectrum antibiotics and they're available only as IV and typically last resort. So an important thing to know is that it does have cross-reactivity with penicillins and cephalosporins because they all have a beta-lactam ring. So important to, I guess, be aware if a patient has a penicillin allergy that it may affect the ability to use other antibiotics such as cephalosporins or carbapenems. But often, I guess, in a real life setting, it's important to differentiate between a true allergy versus adverse reaction. So nausea and vomiting, diarrhea doesn't count as an allergy. I'm sure as you're aware. And so this is just a bit of chemistry here. The next class that's important is glycopeptides. The most important one is vancomycin, and this is the treatment of choice for MRSA. Important adverse reaction to know is red man syndrome, and this is not a true allergy, but due to rapid rate of infusion. So the way to manage that is to reduce the rate of infusion. Next class is aminoglycoside. So the classic one we know is gentamicin, has really good gram-negative coverage. But important to know there is significant side effects. So the main two are nephrotoxicity, which is reversible, and ototoxicity, which is permanent. So this is a reason why in a clinical setting, we don't typically use a lot of gentamicin and glycosides, because there is that risk of permanent hearing impairment. But typically, that's why if we do use an aminoglycoside, we try to use it for the shortest duration as possible and measure the serum concentration to prevent toxicity. Next class is macrolides. So the ones that end with mycin. And this is a good alternative for patients with a penicillin allergy, but important to know that particularly for erythromycin, it has a lot of drug-drug interactions and can prolong the QT interval. So tetracyclines, again, it's good for atypicals. Important contraindications would be children under 8 years due to affecting the teeth and bones, and it should not be given in pregnant women. Other important side effects include esophageal irritation. So when counselling, you have to ask them to make sure after taking doxycycline to sit upright for at least half an hour, and photosensitivity, so make sure they have sun protection. Another antibiotic you should be aware of is clindamycin, which is a lincosamide, and the main adverse reaction is C. difficile, which presents as profuse watery diarrhea after antibiotic usage. Another class would be quinolone, so ciprofloxacin is a common one, good for gram-negatives, but it has a lot of drug-drug interactions. Trimethoprim, as we know, is good for the treatment of UTI, and a combination one is Bactrim, which includes trimethoprim and sulfamethoxazole, and that's classically used for PJP prophylaxis, so in someone who's very immunosuppressed, like in HIV. Another one you might have heard of is chloramphenicol. In a clinical setting, we don't typically use it anymore, except in bacterial conjunctivitis. It's available as in eye drops. And then metronidazole, which we all know is good for anaerobic organisms, and it's a first line for C. diff colitis. And a good important counselling point is avoiding alcohol with this one. So with all the antibiotics, I guess good common knowledge to know is that nitroimidazoles, so your metronidazole or tinidazole, is the ones that you have to avoid alcohol for during the course of the antibiotic and the day after, otherwise it can get a serious reaction in the field. Next one's rifampicin, which is part of TB treatment. It's a RIPE drug, so I think that's already been covered by the rest lectures. Niacinamide is also part of RIPE. So I made a little summary in terms of the different bugs and what antibiotics will cover them. But I think if you want something, I guess, a little bit more high yield, so what I try to do is, I guess, summarize the bug and the drug that you use it with. So if they do ever ask a question about which antibiotic is appropriate, this would be, I think, a good reference table. And then I also like to ask about adverse drug reactions. So as I said, the general things are always like your GIT symptoms and your hypersensitivity, but these have a bit more specific ones. So I think, as I mentioned, C. difficile is most associated with clindamycin use. And then for your RIPE drugs for TB, I guess a good way of remembering is that rifampicin sounds like ripe. So oranges are ripe, so it can cause orange stain secretions. Isoniazid is the one that causes peripheral neuropathy, so you need a supplement with vitamin B6. Pyrazinamide, so P for purine, purine's implicating gout, so pyrazinamide can cause gout. Ethanbutyl starts with E for eye, so that can cause optic neuritis. So that's one way of remembering it. That's a lot to remember. So moving on to empirical treatment. So another exam question. In a sputum of a patient with community-acquired pneumonia, which select the most appropriate organism?
Gram-positive cocci.
I think I'm hearing, yep, D. So it's gram-positive cocci. So in general, a community-acquired pneumonia is caused by strep pneumonia until proven otherwise. And that's 80 to 90% of pneumonia. So in terms of assessing severity, I think you would have already gone through this, but there's a CORB or CURB-65 score, and that helps to determine the setting of treatment as well as what antibiotics you use. And there's also SmartCop, which I don't think you really have to know, but just be aware that's another grading system. And this is a bit of a summary of the treatment for pneumonia. So I think you've gone through this, but there's an ABCD way of remembering it. And I've just listed antibiotics. I think it's already been covered by someone else, so I won't go through that again. And also important to know, distinguish it from hospital-acquired pneumonia, because that tends to be caused by more multi-drug resistant pathogens. So that's why the treatment is slightly different. So for community-acquired pneumonia, if they're well, you use amoxicillin, but in HAP, if they're well, use augmentin durafort because you want to have more broad spectrum cover. And if they're unwell with HAP, you use tazocin, which is more broad spectrum again. So here listed some buzzwords for pneumonia because I often like to ask those type of questions. I think important one is Klebsiella, the red currant sputum. And Legionnaires, I think Legionnaire is like air conditioning, so that's one of the air conditioned units, water-cooled towers. Mycoplasma is called agglutinins and blood film, and strep pneumonia is important. That's the one with rusty-coloured sputum. So the next question, so we have a 53-year-old thin homeless man presents to the community health service with a persistent cough and hemoptysis. A chest x-ray shows a cavitating lesion in the left lung apex. So what's this? Yeah, so it's TB. Yeah, tuberculosis. So the classic presentation would be the lesion in the left lung apex, which is most likely a GON focus. So that's like pathognomonic for TB. And I guess, put some notes here on TB. I think it's already been covered in your rest lectures as well. I think but important to remember there's a lot of extrapulmonary manifestations of TB. So if you ever suspect TB, also important to have a full head to toe systems review to look for the other complications, which are listed here.
They're just like putting
and investigations and active TB. Best thing if you can do is a culture, but obviously it takes 4 to 6 weeks to come back. So often you start empirical treatment anyway. And in terms of, I guess, what investigation is best for latent TB, quantiferin is the best test. The MAN2 can be have a false positive due to a BCG vaccine. That's why you use quantiferin if possible. And if they are actively having TB, the best test is a sputum culture. And then I also went through the TB treatment. So another thing in addition to the side effects is knowing the duration of treatment. So as a rule, the minimum is 6 months of therapy. But the bottom two, so RIPE, the PE, the bottom two, you drop off after 2 months. For the rest, but rifampicin and niacin at least 6 months. And then another respiratory infection is influenza, which is again another green matrix condition. So it typically presents with, your coryzal symptoms, your cough, fever, chills, but also headache and myalgia. I guess the main thing to take away from this is that, main thing to take away is that you only use antivirals in high-risk groups and within 48 hours of symptoms. And the two main options you have is Tamiflu, which is oseltamivir, or zanamivir inhalation, which I've never seen used. And then I listed what high-risk groups are. So obviously elderly, people with pregnancy or other chronic health conditions, or ATSI as well. And a definitive diagnosis, but often not needed because it's clinical, you can do a viral culture. And also important to know that influenza can be complicated by secondary bacterial pneumonia as well. So that's important to keep in mind, that even though it could be viral, it can become bacterial. The next topic is UTI. So as we know, the most common organism is E. coli. That's over 80%, but there's also other bugs that can be implicated. And the treatment, first line for just a simple UTI or cystitis is trimethoprim or cefalexin or augmentin duofort. But if it's paranophorus, so if it's ascended from the bladder to the kidneys, you need IV antis, so gentamicin and amoxicillin. And for pregnant ladies, you need to avoid trimethoprim because it's a folate antagonist. So then options would be nitrofurantoin or cefalexin. Just a little, I guess, a clinical point. So as we know, females are more predisposed to having UTIs, and that's due to the anatomy, I guess, of the urinary tract. So that's why females get a shorter course of antibiotics. So typically 3 days versus a male, you need to treat for at least a week. Another, I guess, thing to keep in mind is asymptomatic bacteriuria. So this is very prevalent in elderly patients. So it's important to know that just because someone grows bacteria in the urine or has pyorrhea, it's not indication for treatment. You typically only treat a UTI if they're symptomatic, so if they've got dysuria or polyuria or something. But there are two circumstances where you would treat even if they had no symptoms. So that's prior to urological surgery or if they're pregnant. So next question. 21-year-old female presents to ED with a 12-hour history of increasing headache and neck stiffness. She's no allergies. On examination, she's agitated, she's febrile at 38 degrees, she's photophobic with a positive Koenig sign. You also note a purpuric rash on her hands and feet. So then, first we think, what's a diagnosis? And secondly, what do I treat it with? Yeah. So this is Neisseria meningitidis, so the signs of meningitis, so the neck stiffness and headache. And you know it's more specifically Neisseria because of that purpuric rash, which is classic. And the targeted antibiotic treatment is benzylpenicillin, although you can argue ceftriaxone would be also okay. But if you look, I guess, more at the guidelines, the directed treatment for Neisseria is benzylpenicillin, although empirically you could use ceftriaxone with dexamethasone, and the dexamethasone is to control cerebral edema. So here I just listed some, I guess, how it presents. Won't go into that. I think it's covered by neuro. And in terms of the antibiotic treatment, I think just important to highlight that although ceftriaxone has really broad coverage and we use it very often, it doesn't cover one of the bugs that's implicated in meningitis. So it doesn't cover listeria. So that's why it's important in patients with risk factors for listeria. So such as if they're immunocompromised, that they use benzylpenicillin because ceftriaxone doesn't cover this. And then I just made a table of the most common causes of meningitis and I guess the differences in those. And then just, I guess, what you see on LP as well, which you can read. And then the bugs implicated in meningitis. So I think this actually came up in a pathology exam, like a newborn with signs of meningitis, what's the most common organism? So that would be group B strep. So I think it's important for us to know the most common ones in adults and the most common ones in like a newborn. And then that's just I guess, algorithm as how to treat meningitis. I don't think we have to know. Next question. A 60-year-old man presents to the GP with a 4-week history of lethargy, loss of weight, and night sweats. Examination reveals pallor, a mitral regurgitation murmur, microscopic hematuria, and mild splenomegaly. And then this is confirmed with FBE, so low, so she's anemic, has elevated white cell count, slightly reduced platelets, normal MCV, and reduced renal function. What's this? Yeah, so it's infective endocarditis. So I guess the main take-home message is heart murmur plus infective symptoms is infective endocarditis until proven otherwise. And the other symptoms such as the splenomegaly, the hematuria, are all signs of the septic emboli and infective endocarditis. So I just put some notes here. So I'm sure you're aware. So the mnemonic to remember the features of infective endocarditis, you can use from Jane's, which is, I think, pretty good. And in terms of the presentation, you can think of it as either acute or subacute. And that's important because that, I guess, means there's likely a different organism implicated. So with acute presentation, typically occurs in someone with IBDU, and the most common organism is Staph aureus. And the treatment for that, one way of remembering it is BFG, so big friendly giant. So you use benzylpenicillin for B, F for flucloxacillin, and G for gentamicin. But that's only if they have their own native valve. If they've had previous like heart surgery and have a prosthetic valve, then the antibiotics are slightly different. So you give, instead of the benzylpenicillin, you replace that with vancomycin. So you use gentamicin, vancomycin, fluclox to cover for MRSA. For subacute, the most common one, organism strep viridans, which is typically, I guess, found in the mouth. And then we'll just listed investigation. So I guess the most important would be the blood culture, followed by the echocardiogram. And this is a diagnostic, this is like the actual diagnostic criteria. I'm not sure you have to know, but main thing is the two major criteria is the blood culture and echo. And then the minor criteria, you can remember the mnemonic is fever, but I'm not too sure if that's too important. But just there for your reference. And then the treatment, so as I mentioned, empiric therapy with BFG, big friendly giant, and it has to be at least 6 weeks, so prolonged IV therapy, so they're likely to have hospital in the home. And there's also important to remember that might need also surgical management if they're not responsive to antibiotics or if they have heart failure, or there's a mnemonic phase where you can maybe help remember when you would consider referral to cardiothoracics. And another condition that I used to get really confused between was infective endocarditis and rheumatic fever. So because they're both like heart conditions and both related to infection. So what I remember the difference is rheumatic fever is like rheumatological, so it has joint involvement, and joint involvement is the first major criteria in the Jones criteria, so J for joint involvement. And the treatment for rheumatic fever is benzylpenicillin, because the organism most implicated is strep, group A strep, so that's why I use benzylpenicillin. And the cardiac murmur that's most common is mitral stenosis versus infective endocarditis, which tends to have a regurgitant murmur. So that's another way of remembering the difference. So next question, 84-year-old man who was hospitalized for IV antibiotics for treatment of severe episode of pneumonia. 2 weeks later, he developed watery diarrhea. Yep, so it's D. So antibiotics plus watery diarrhea equals C. diff. It's simple as that. So I just have some general things about gastroenteritis. So most of the time, we don't actually have to treat them with anything. Just oral rehydration is sufficient, but there are certain circumstances where you would do a fecal MCS and consider antibiotics. So if they have bloody stools, they're septic, the return traveler, the immunocompromised or systemically unwell, that's when you might consider antibiotics. And if you, and then if you do, usually it's norfloxacin, but if it's for Giardia, you'd use metronidazole. So in terms of the most common cause of gastroenteritis, nearly 80% is viral, and the two main viral ones are rotavirus and norovirus. So rotavirus typically affects infants and children. One way of remembering rotavirus affects kids is that kids are rascals, so rascals rotavirus, which is versus norovirus, which is more adults or all age groups. And then so then most common is viral, and then another cause would be bacterial. So then I try to make a table of all the different bacterial pathogens that we have to know and their associations. So Campylobacter will be associated with bird or animal droppings or unpasteurized milk. Salmonella is contaminated chicken. Shigella, this is a past exam question, it was a bit odd. It would be in a sex worker. E. coli would be return traveler, or, and Bacillus cereus, like cereal like rice, is fried rice. And then Staph aureus would be ingestion of like bad food. So in terms of the ones that would present very soon would be Bacillus or Staph aureus, because they have a preformed toxin. So they have symptoms very soon after having the exposure. So C. diff, as I mentioned, it typically post antibiotic use, and Vibrio, I don't think that's that important. Listeria would be unpasteurized milk or cheese, and Legionella, again, Legionella would be the water, towels, spas, or baths. And then in terms of if they have diarrhea and it's with blood, then that narrows down your differentials even more. So it narrows it down to these organisms, and a way I remember it is Chessie, and then, or Chess, and I just listed the, I guess, the associations with each of the bacteria. Next type of things that can cause gastroenteritis are parasitic infections, and these tend to have a longer incubation period or have longer duration of symptoms. For Giardia, the classic symptom is steatorrhea, so having floaty, smelly, stools, and the classic is the egg burp, and you treat that with metronidazole or tinidazole. And there's another Entomobia histolytica, sorry, I can't pronounce it. That's associated with an overseas traveler with tropocytes and liver abscess. So moving on to other GIT infections. So the first I want to talk about is the bowel infection. So things like your appendicitis or diverticulitis. So in general, because intra-abdominal infections are polymicrobial, you use a combination of antibiotics that covers gram-positive, gram-negative, and anaerobic. So you use AGM is the way I remember it. So amoxicillin for enterococci, gram-positive, gentamicin for gram-negative, and metronidazole for the anaerobic. And I just listed some other things. So C. diff, metronidazole, and vancomycin oral. Important to remember that vancomycin has to be oral for C. diff, because if you give it IV, it's not going to be absorbed into the gut, so you have to give it orally. For H. pylori, the treatment of choice is ACE, so A for amoxicillin, C for clarithromycin, E for esomeprazole, and also the quadruple therapy as well. Moving on to skin infections, so cellulitis. The most common cause is what? Is staph. So then you use flucloxacillin first line. But if you're worried about methicillin-resistant staph, then use vancomycin. Another important condition to remember is necrotizing fasciitis, which often looks like cellulitis to begin with, but the main, I guess, finding would be pain out of proportion to the extent of appearance. And then in this case, you need to treat it with broad spectrum antibiotics, so meropenem. And in diabetic foot, because it's a polymicrobial infection that tends to be implicated, you go, if it's a mild case, you can use augmented Durafort, and if it's severe, use Piptaz. So I've covered a little bit more on cellulitis because it's a green condition under derm. I've already listed the antis here, and it's important to remember differential diagnosis as well. And then other group infections, your joint infections, so septic arthritis. The most common organism implicated is Staph aureus, so you treat fluclox, but if they're sexually active, do consider gonococci as a cause. And again, for osteomyelitis, the most common organism is Staph aureus, so again, use fluclox. In terms of surgical prophylaxis, the antibiotic of choice is cefazolin IV, and it tends to be given roughly about 60 minutes before the procedure. So that's the antibiotic of choice, and that's to cover the skin bugs. And I also listed the antibiotics of biofilm, which I don't think you have to know, but just out of interest. And then moving on to STI. So I think it'd just be important to remember what antibiotic goes with what STI. So syphilis, you would use a benzamine penicillin, chlamydia, azithromycin, and then gonorrhea uses azithromycin plus ceftriaxone. And move on to the next question. So John is a 29-year-old man admitted to the ID unit with a history of flu-like illness. His medical history and physical examination reveals a recent weight loss of about 7 kilos, including diarrhea for the past 3 weeks. He's had a night sweats as well as enlarged glands in his neck and under his arms. He has a diffuse rash over his back. His temperature is 38.5 and he's complaining of chills and generalized tiredness and weakness. Here are his lab results. So what is the most likely diagnosis? So it's HIV seroconversion illness, and the main, giveaway is in the investigation results. So there's a low CD4 count. And although HIV ELISA test is negative, it could be because it's in the window period. So thinking about the natural history of HIV, so in this case would be in that primary stage where he's symptomatic and there's a rapid decline in CD4 count before it rises again. Important to remember that the CD count correlates with a clinical symptom. So often patients with CD count over 500, they have no symptoms, versus stage 4 AIDS will be less than 200 cells. In terms of risk of exposure, the highest risk would be transfusion from infected blood sample. And then there's other means of transmission from mother to child, as well as intercourse and IVDU. I just put here the transmission risk by exposure in comparison to other blood-borne diseases, because a few years ago they had an OSCE station or a needle stick injury, and I think that threw a lot of people off. So if that happens again, an easy way to remember what's the risk of transmission of Hep B, Hep C, and HIV, it's in 3. So Hep B is 1 in 3, Hep C is 1 in 30, and HIV is 1 in 300. So the risk of transmission of HIV is actually quite low in comparison to the other blood-borne diseases. In terms of a history, so it's a lot of words. The first column is more if it's the first time they've been diagnosed, what type of questions you'd ask. And the second column is more if they've had a diagnosis, what are the things you want to check out for? And this is the symptoms of the seroconversion illness. And in terms of investigations, the most important thing to remember would be the ELISA test and the Western blot. So ELISA test is good for screening, and that can become positive within 15 to 20 days of infection. But Western blot takes longer for it to be positive. It might take 35 days, and that's more diagnostic. So ELISA is more screening, and then Western blot's more diagnostic. And important to remember that the HIV antibodies may not be detectable until 3 weeks, so that has that window period. So important to get the patient to come back if it's within a short time frame. I also listed here what things you need to monitor for, and also think about other comorbidities and complications. So doing a full STI screen. And moving on to treatment. So the mainstay of HIV treatment is medical, and all patients are treated with antiviral retroviral therapy, regardless of the CD4 count, because we know that has better prognoses. So they usually have a treatment with a combination of different antivirals. And important to stress that compliance is essential, because compliance, even less than 95%, is associated with treatment failure. I'm also listed here what other prophylaxis you need to consider and things to watch out for while they're on therapy, and what to review for. There's also potential surgical management through bone marrow transplant, but that's not really typically used, and it's high risk of complications. So mainstay is medical. In terms of counselling, if it ever comes up as a station, this could be one way of going about it. So always confirm diagnosis first, talk about medications and monitoring, think about harm reduction strategies, think about prevention of transmission of other diseases and prevention of other disease. It's really important to remember support and talk about the complications. It's important to also remember, your legal implications. So HIV is a disease that needs to be notified to the Department of Health. We have to reassure that all the data is de-identified and it's purely for data collection purposes. Also important to remember sexual partner tracing, and a good website for notifying partners if the person doesn't feel comfortable is a let them know website, which is completely anonymous. And then if the HIV is not being well managed, it can lead to AIDS, and this is like the complications that can arise. So the way I think of it is there's infectious complications and malignancy complications, and I guess more degenerative complications. So infections like your PJP, malignancies, your Kaposi sarcoma, and your degenerative would be like your AIDS dementia wasting syndrome. And this can easily come up as a Breaking Bad news station. So I'm sure you've heard of the spike mnemonic to help, I guess, structure a framework to address it. Next slot is travel-related diseases. So this can, I guess, be come up as a fever and a return traveler history. And I guess another mnemonic to help, I guess, remember what questions to ask in that circumstance is cheek F toads. So thinking about what country they went to, what housing they were living in, are they immunized, what context they have, food and drinks, travel activities, occupation, animal contacts, drug use, or sexual history. I think it's a good screening tool. And the top differentials in any travel-related history, if you always remember to think about malaria, dengue, and typhoid, as well as Hep A, your gastroenteritis, TB, and influenza. So then what I try to do is, I guess, summarize each of the main travel-related conditions. And I guess the first row would be, I guess, the most high yield. So dengue is associated with retroorbital headache, acute onset high fevers, and break-bone fever. That's the classic presentation. In contrast to malaria, the classic presentation is swing fevers, jaundice, anemia, and hepatomegaly. Sorry, I can't say that word today. And then typhoid has the rose spots. And it's interesting in that this can cause both diarrhea and constipations. And also listed here the top 3 causes of massive spleen. So you can think of the 3 M's. So malaria is always a differential to keep in mind. And then investigation. So for malaria, I think would be the most important condition to know of. So the investigation of choice is thick and thin blood film. You need both blood films, important to mention both. Thick is to see the parasites, and thin is to actually look at what the morphology of the parasite is, because there's different types of malaria. And in terms of prophylaxis for malaria, I should go back. The most common choice would be a doxycycline, and there's other ones as well, which are used less often due to cost. And the last thing about ID I put in here is a septic screen, because I think on the wards they often say, oh, let's do a septic screen, but what does it actually mean? So I just listed here what the investigations are, more out of interest. So I might move on to the next presentation, otherwise I might run out of time. Any questions before I move on to the next slide? How do I? Okay, I might move on then. All right. So next slide is breath, path, and derm, which is a lot of stuff. I've also uploaded info on your MSK and heme path, so you can look at that as well, which is not going to be included here because it's going to be too long. So let's get started. So tips for pathology. So I'm sure you're already aware, but do your Moodle quizzes like multiple times. I felt like 90% of our paper 1, which had pathology, was directly taken from Moodle. So make sure to do that again and again and again and again and again, because it will likely to come up. And also another good reference is the Limpincot's illustrated Q&A book, and especially focus on the questions with the pictures, because they often take that same picture into the exam. So I would recommend doing that if you've done your Moodle quizzes, if you want more practice. I've linked the PDF if you want to have a look. So first things I wanted to cover was the glossary, because I think the hardest thing for me for PATH personally was the terminology and the language. So if you know what the word means, it also helps to narrow down differential. And so if you, I guess, know what the suffix is and what the prefix is, it tells you where's the origin of the the cancer or the lesion, and then is it benign or malignant? So I'm gonna let you have a read. And then different words as well. So also listed here, which I'm sure you're pretty familiar with. I guess, sorry? Oh, sorry. Is it not working? Sorry. So yeah, oops. Yeah, so sorry. Yeah, I think the main thing to highlight here is the metaplasia. I think you really have, they like to ask about Barrett's esophagus, so just remember that one. And then difference between grading and staging, which is something also got confused as well. So grading is more histological versus staging, which is more clinical. And then they sometimes like to ask about pathology stains as well. So just listed some here for you to know. There's more associations. So let's firstly cover breast, and it's actually listed as a green condition in terms of breast cancer. So cover that. In terms of an approach to breast pathology, I think the best way to think about it, like with, I guess, even any condition, is it benign versus if it's malignant? And that way it narrows down your differentials. So I've listed here some features you look at if it's benign versus if it looks like it's been malignant. And I linked a video here, which is a video which I used to get a lot of mnemonics from in this presentation. So some of them may be a little bit inappropriate, but I think that's really good to help, I guess, jog your memory. So you can watch that later in your own time. And it's so important to know about breast cancer because it is very common and it's the most common female malignancy. And there's a lifetime risk of about 1 in 8. So in terms of breast cancer workup, I'm sure you've all heard of the triple testing. So triple testing, I don't know why it was 111, should be 1, 2, 3. The triple testing involves firstly clinical assessments, so history examinations you do for everyone. And then secondly, breast imaging, which includes mammography or ultrasound. So important to know the age of the patient. So you only do mammography in a patient who's more than 35 years.
My stream's working, bro.
Because of the high breast density. So mammography may not be accurate picking things up in a younger
Oh, really?
In terms of the breast screen available, so the breast screen is available for free for all women in Australia aged 50 to 74 every 2 years and early for family history. So it's important to keep that in mind as well. And the third part of the triple testing is your biopsy. So that you use that if the mammography ultrasound scan has some suspicious findings, then you refer for biopsy. So that includes typically a core excisional biopsy and fine needle aspirate. In terms of taking your history, important to target it so that you're looking out for risk factors. So risk factors mainly due to excess in estrogen. So things like frequent periods, use of HRT or oral contraceptive pill, nulliparity, so not having children, and early menarche or late menopause. Also important to ask about is family history, in particular of other cancers as well. So for example, Lynch syndrome is an inherited condition that increases the risk of breast cancer as well as endometrial, ovarian, stomach. So important to ask for other cancers as well. In terms of the workup, so you've got your triple testing, and then you also go MET workup if you're worried about it being malignant and worried about it spreading. So typically breast cancer metastasizes to the bone, so bone scan is really important. And also listed here the staging as well. So in general, I'm not sure if you have to remember this, but anything that stage 4 is metastasized. Anything stage 1 is more local. Stage 2 typically has affected like a local node, and then stage 3 typically affects more extensively with the node, but without metastasis. Also listed, put here breast exam. I'm not too sure if it will come up, but it's here for your reference. So moving on to benign breast conditions. So as I said, think about breast condition as benign versus malignant. So benign ones, I've listed here. So the first one listed is fat necrosis. So that typically occurs post direct trauma to the breast. And there's a picture here of a way to remember it as well, which I won't say out loud. And then Another condition is acute mastitis. So that typically occurs in a postpartum woman who's breastfeeding, and the bacteria implicated is Staph aureus. So the treatment of choice for that is Flupox. Another important differential is simple cyst, which is typically just a lower but painful lump in an older woman. So next condition is fibroadenoma, which is the most common benign breast tumor. And that just tends to fluctuate with the menstrual cycle. So for example, in pregnancy, it can increase in size, and it can also present as cyclical breast pain that comes in sync with the menstrual cycle. This presents as a single unilateral, firm, rubbery, well-discrete mass and tends to be painless. Compared to fibrocystic change, this tends to be more multifocal and can be bilateral, and it tends to be not as well circumscribed. And on appearance would be, you can see cystic dilation of ducts, versus fibroadenoma, you can see is a well circumscribed mass. Next condition is intraductal papilloma, and that typically presents as serious bloody nipple discharge. Another benign breast condition is Phyllodes tumor. So Phyllodes tumor has a typical leaf-like pattern, but it can also be malignant as well, but typically benign. So Phyllodes is leaf, and gynecomastia is increased breast growth in a male. And the most common drug implicated in that is listed there is spironolactone, so important adverse effect to know. And ductatasia is another condition listed there, which I don't think is as important. So moving on to malignant breast conditions. So when you think about malignancy, you have to think, is it in situ or is it invasive? So in situ means the cell growth is contained in the duct in terms of DCIS, or in the lobule in the case of LCIS. So typically it doesn't have a mass on palpation and there's no basement membrane penetration. So I guess the way to remember ductal versus lobular is the 3 C's. So ductal has E-cadherin, has a myoepithelial cell layer, and has calcifications, in contrast to lobular CIS. And that's important clinically because the E-cadherin connects cells. So that is why the lobular carcinoma is more likely to metastasize compared to the ductal. So malignant breast condition, so ductal carcinoma in situ, so explained, and the invasive ductal carcinoma is the most common malignant breast cancer, and that has the highest risk of metastasizing to the lung. So a common presentation, a common sign would be accountable met to lung chest X-ray. So if the patient has a history of breast cancer, it's most likely due to IDC. Moving on, there's LCIS, which I've mentioned as well, and that tends to be more bilateral compared to the ductal carcinomas in situ. And the classic appearance for the invasive lobular carcinoma is single file appearance. So if you see single file appearance is ILC, that's all you got to know. Next condition is Paget's disease. So that typically presents as a scaling erythematous lesion or rash on the nipple, and that can sometimes be confused with eczema. The way to differentiate between Paget's disease and eczema is that in eczema it tends to be very itchy, there's no underlying lump, and the nipple is intact, versus Paget's disease. And I guess a classic sign would be the presence of Paget cells will look like clear halos. Next malignant disease is inflammatory breast cancer. So this has a very poor prognosis and typically presents with purpura, so it looks like an orange, and that's due to dermal lymphatic edema, and then tends to also have swollen and tended breast. So what do you get on a pathology report? So I listed some things here. I guess the main take home to think about is the hormone receptors, because that changes your management. So the 3 main hormone receptors or receptors we look at are estrogen, progesterone, and HER2 status. Important to remember that triple negative breast cancer has the worst prognosis because we don't have any targeted medicines or therapy. So in terms of management for breast cancer, like with any cancer, it's multidisciplinary, and you also have to think, is it curative or palliative? So can we cure this cancer, or is it more for symptomatic relief? So generally, if it's early stage cancer, you opt for surgery to remove the primary tumour through a wide local excision, and you also like to do a sentinel lymph node biopsy and removal if needed. The second type of therapy to think about is radiotherapy, as well as, and the third is chemotherapy. So it could be neoadjuvant or adjuvant. In terms of hormonal therapy, if it's estrogen receptive cancer, you can consider tamoxifen or aromatase inhibitor. So important to know that tamoxifen can be used for pre or postmenopausal women, versus aromatase inhibitors can only be used in postmenopausal women. And targeted therapy for HER2 is a trastuzumab, which is a monoclonal antibody. If it's metastatic disease, then surgery becomes less of the priority, and you tend to use chemo or radiotherapy for bone mets. And it's also a high risk of recurrence, so important to keep that in mind. And often these women have early menopause due to the side effects of management. So moving on to dermatology. So the green conditions I'll cover, except for cellulitis, which was on the other ID slide. Again, dermatology, there's a lot of terminology to keep in mind. I personally actually don't remember all of this, but important just, I guess, to know the difference between papules versus macules. So with papule, you can palpate, versus macules, you don't. Scale is flaky epidermis, which is like seen as in psoriasis, versus crust, which is seen such as in vitiligo. And the two main ways or strategies to describe a rash, if it's like a erythematous rash, you follow the skull mnemonic, which I'll go into later. And it's a pigmented lesion, you go for, you use ABCDs to help describe a lesion. In terms of if it did come up in OSCE, one tip one of the seniors had was that if you're pretty confident with the diagnosis, instead of, I guess, trying to describe a lesion in front of you, which can be quite daunting, you can work backwards in describing lesions. So if you know the classic feature of psoriasis is like silvery scale, then you can just mention that, if it might help in that case. So in terms of approach to a rash examination, so it probably won't come up as an OSCE, but I've just listed here for your reference. In terms of describing the lesion, the SCAR mnemonic was size, shape, surface, C for color, A for arrangement, L for lesion morphology, and D for distribution. So the first condition I'll talk about is eczema, aka dermatitis. These terms are interchangeable, but important to know that although dermatitis means skin inflammation, not all skin inflammation is dermatitis. So for example, psoriasis has inflammation, but you wouldn't call psoriasis dermatitis. So it's just a bit of a terminology thing. And eczema typically presents with itchy erythematous scaling rash, and it tends to affect the flexor surfaces. A good way of remembering the triggers for dermatitis is scratch, so I've listed there, and that also helps with your counselling. So avoiding the triggers is usually the first line management for dermatitis. There's also different subtypes of dermatitis. I think only the top two are the ones that you have to know. The rest is more for interest, I think. But your atopic dermatitis is the one that's classically associated with asthma and hay fever, and that's IgE mediated, so type 1 hypersensitivity, versus allergic contact dermatitis, which is type 4, and that's more due to exposure to allergens such as a belt buckle from nickel allergy or from a plant allergy. I think those two are the only ones I think you have to know. In terms of management, so as I said, first thing you do is avoid scratch. Make sure to moisturize a lot, the greasier the better. And then if that's insufficient, you can consider topical steroids. So a mild one such as hydrocortisone for the face, and you can use a stronger steroid for the body. You can also consider antihistamines for symptomatic relief of the itch, and also important to monitor for complications such as infection. So the main problem in eczema is, I guess, defect in the skin barrier. So that leads to inflammation. That can also be a portal of infection. And then obviously at the end, you can always refer to a dermatologist. Also listed here, the differences in therapy options. So ointments are more oil-based versus gels, which are more liquid or fluid-based. And obviously in eczema, you tend to go for ointments if you can, but they typically are not that well tolerated because they feel really greasy. So most common people like to go for creams. Also listed here some adverse effects of topical steroids, which I may ask. So that's the reason why we try to limit steroid use to the shortest duration possible, because it can lead to easy bruising, thinning of the skin, but you can reassure patients because most of it's not systemically absorbed. It's only an issue if it's long-term use. It's quite safe generally. Another condition is seborrheic dermatitis, which I think is more for your year 4C. This tends to present with a fine greasy scale in the face or the scalp. I don't think you have to know, but that's there for your reference. Next common condition is psoriasis. So this is a type 4 hypersensitivity of the skin that increases skin turnover. Tends to affect, has a bimodal distribution of age from the younger person versus an older adult. And it's important to remember some triggers. So for the gut tape form of psoriasis, it typically follows a streptococcal infection. And certain medications such as beta blockers also implicated as well. There's also the Koebner phenomenon. So after injury or irritation, like for this picture here, one with the scratch marks, that can also predispose to psoriasis. So the classic description of psoriasis is well demarcated plaques of silvery scale. And it's also important to know the nail changes, because I think they like to ask that a lot. So it's important to do, I guess, in a derm exam, if you were to get a derm exam, as well as a rheumatological exam. So nail changes, a good way of remembering is sporo, which I've listed here. Also important to know, there's also a huge psychological impact, the arthropathy I mentioned, as well as increased risk of metabolic syndrome. And sorry for the gory pictures, but it's just to show that psoriasis can look different in different areas of the body. In terms of management, you always start with non-pharm, so avoiding triggers. Then consider steroids if it's mild. If it's moderate, you can refer for phototherapy, and if it's severe, you can use your biologics. And along the way, always remember holistic care, so that psychological support and looking out for the cardiovascular risk factors. As I mentioned, the subset of gut tape psoriasis is the raindrops. So I guess main thing to know is that follows strep infection and it looks like raindrops. That's the main thing you have to know for that one. And I just listed here differences between eczema and psoriasis, because I sometimes get confused between the two. So hopefully this might help a little bit, but you can read this at your own time. But yeah, eczema is more flexor and then psoriasis is more extensor. This also helps to differentiate the two. And the age group. So eczema is more infants and children and psoriasis is more adults. Next, I don't think I have to cover this. I think it's more GP, but for your reference, acne and then rosacea, I think is more for next year rather this year, but I think you can get this later. Moving on to neoplastic lesions. So I didn't create this, but the main things I think to know for year 3B is your malignant one. So on the squamous spectrum, your SCC, and then your BCC and melanoma are the three main ones we'll cover today. So in terms of neoplastic lesions, so it'd be important to know, I guess, the cell origin. So squamous is from the keratinocyte, the basal cell is from the basal cell, and melanoma is from the melanocyte. So it's pretty straightforward. Also listed here a bit about screening for skin cancer. There's actually no formal, I guess, program in place, but they recommend all people over 65 to get an annual skin check, especially if they're at high risk. We'll do it a bit earlier. So here's an exam question. So Bob Brown, 91, presents to you with a lesion on his side of his nose, has a scab, has had it for many years and occasionally bleeds, has raised edges. The edges appear white, however, they have overlying telangiectasia. What is this? Yeah, so it's a basal cell carcinoma. Awesome. So I think it's really important to know the difference between BCC and SCC. Of the two, BCC is by far a lot more common. In terms of SCC, you can think of it as on a spectrum. So it tends to start off with actinic keratosis, then it leads to Bowden's disease, which is SCC in situ, then SCC, which is when it goes past the basement membranes. Important differential is keratocanthoma for SCC. So I think this is important to know the classic description. So SCC has a hyperkeratotic lesion with crusting ulceration versus BCC, which is that shiny, curly papular nodule with umbilicated center and telangiectasis. So moving on to pigmented lesions. So this is ABCD approach for melanoma. So is it asymmetrical? Does it have an irregular border? Is it color variegation? Is diameter more than 6 millimeters? Is evolving? Is it elevation? Is it ferment? Is it growing? So the last EFG is more for nodular melanoma, which is more of the most severe of the melanoma subtypes. So this is an exam question. So 64, atypical melanocytes extending along the basal layer of the epidermis in skin biopsies from the forehead of damaged skin. What's that? I think so C, is it? And then atypical melanocytes present within the reticular dermis in the skin biopsies from the back of a 50-year-old. Okay, I'll go through these. So 64, yeah, it was answer C for lentigo maligna. So it classically presents as a pigmented lesion in the forehead of an older person. And then 65, answer is A, melanoma Clark level 4. And the way to remember Clark level is, you can think of it as PR. So if there's 5 levels, 3 is in between, that's between P and R. Anything above that is, so 2 is papillary and 4 is reticular. Anything like that's 1 that's more above is above papillary, and 5 is below reticular. So if you remember PR as 3 is being between P and R, it helps you remember the different levels. So a bit more about melanoma. So melanoma is always malignant and it's formed from the melanocytes. And I just listed some differences between melanoma and SCC and BCC. So interestingly, melanoma is associated with shorter exposures to the sun versus BCC, SCC is more directly correlated with sun exposure. In terms of, I guess, what's important to know, Breslow thickness is the most important predictor of prognosis. So that's a commonly asked question. So if they ever ask, what's the most important factor to determine the prognosis of a patient with melanoma, it's the Breslow thickness. The thicker it is, the worse the prognosis. And then in terms of the subtypes, there's 4 different subtypes. So the most common is superficial spreading, which has a good prognosis. And then the second one is lentigo maligna, which is the previous question. So that has the best prognosis because it's more radial growth. Acrolentigous is associated with poor survival, and it actually typically affects under the soles of foot or mucosa, and it happens in darker skin types, and it's unrelated to UV exposure. And then lastly, the nodular melanoma is the worst prognosis because it's associated with most amount of vertical growth. So more vertical growth is worse prognosis, so greater Breslow thickness. In terms of investigations for skin cancer, always start with the top to toe skin exam and dermatoscopy for suspicious looking lesions. So basically looking at a microscope, and from there you determine which lesions to biopsy. The best type of biopsies is excisional biopsy. And important to remember, we try to avoid punch biopsies because it's a risk of potentially spreading the tumor cells if it is malignant. And then from there, you can also consider sentinel lymph node biopsy if required. Listed here, the Breslow death is more prognostic and the Clark level is more anatomical. So in terms of management early melanoma, early surgical intervention by wide local excision would be the definitive treatment, and the margin would be at least 5 millimeters. So what I mean by wide local, that means at least 5 millimeter margin. Can also consider drug treatments if it's metastatic. There's immunotherapy, targeted therapy, or chemotherapy. Also, you can consider radiation therapy or customized palliative care depending on how far it's spread. Always remember to talk about prevention, so slip, slop, slap, sleep, slide as well, as part of your counselling to prevent further recurrences of skin cancer. I'll quickly go over ulcers as well. So I'll try and make a table on to summarize the main features. So arterial is dry, painful, Venous is more wet, superficial, plus or minus pain. Neuropathic tends to occur in a diabetic person with peripheral neuropathy, and it's painless ulcer in the foot or pressure area. Lymphatic is a very wet ulcer, which I don't think you really have to know. And pressure ulcer tends to occur in someone who has poor mobility and has a lot of pressure to their bony prominence. So then, so this is a really big table, but I just try to summarize everything on one slide. So your arterial, venous, and neuropathic ulcer. Just little things to highlight. So with arterial, important to think about the risk factors for someone if you're thinking an arterial ulcer. Or, so the way I remember is A, B, C, D, E's, F's. So A for age, older person, B for BP, hypertension, C for cholesterol, D for diabetes, E for exercise decreased, family history, and smoking. So I think it's important to, I guess, for any cardiovascular history even, to make sure you ask those specific risk factors. And I think ABC is just a really easy way to remember it. I think important to ask the OSCE situation. And then clinical will be your 6 Ps of ischemia. And then I also listed here the investigations and the management. Typically, all the management, you always start with conservative. So your SNAP-W, which I'm sure you know is, is your smoking, nutrition, alcohol, physical activity, and weight. And then from there, there's more specific medical management, which I've listed there as well. And then I've just listed here different types of derm pathology and associated buzzwords. So I've only went through, I guess, the main green conditions today, but then for the path exam, I like to test some more weird and wonderful things. So here's some buzzwords which you can read in your own time that sort of helps you, I guess, determine which of the conditions are most likely. So I've just listed there. I think that's it. Any questions? It's a lot. Thank you. Well, Ryan's fine.
There's pizza outside. For the vegans and not gluten-free people, there's pizza on the right-hand side. Otherwise, all the pizza on the left-hand side. So it's right.
Oh, sorry.
Thank you.
That's okay. I stop recording.
Oh no, that's good.